Okay. Alrighty, so we're going to do this exam 2 review, and I know it's super late. My apologies. It's the only time I will be able to do it. So let's knock it out, and it'll be recorded for y'all. It is 10:08 on Sunday evening. Happy Father's Day to all you fathers out there, and let's get this done. All right. So for my UTA class, we have your Module 2 exam is on Tuesday, the 17th. It's at the beginning of class. And for my UT Dallas classes, it is on Wednesday, the 18th at the beginning of class. So we're going to do that exam 2 review that you have on your Canvas. Let's pull it up, get it done. Oh goodness, hang on. It like spazzes every time I do that. Okay. So we're going to come down here to exam 2 review. All right. So Module 2 is all about medical emergencies, but I want you guys to understand, remember that everything is cumulative. So, or this class is cumulative. We just build and build and build on everything that we do. So we will, you're going to see some Module 1 stuff. Definitely expect to see some BLS things. Expect to see, taking care of those life threats. If you see your patient with respiratory failure, making sure that we, jump on the airway and take care of the airway. Suction if needed, bag that patient if their tidal volume and their respiratory rate isn't appropriate. Things like that. All of that stuff is going to be part of this, right? Because even if our patient is complaining of a medical emergency, and that if they stop breathing, then we still have to manage that. So you may know that, hey, they just had, a seizure or a stroke, and all this stuff and you recognize this. But again, if something happens with their life threats, we have to take care of that immediately. So we're going to go over this exam 2 review, and there's quite a bit on here because there's quite a bit of body systems. When you think about it, we've got our cardiovascular system, respiratory, GI, GU, endocrine, neuro, right? We have there's more, right? But we've got all of this stuff that could possibly have medical emergencies. And so we have a lot to go over. Plus you guys have and this is important, that yellow emergency chart, your yellow, orange, red, and the first half of your green deal with all of your medical emergencies. So really make sure those are done and completed and submitted, right? If you really take a look at that stuff, we're going over a lot of the major medical emergencies as far as signs and symptoms, how we treat it, what to recognize and stuff like that. And that will really help you when we're, when you're doing your scenarios and of course, when you're taking this exam. So, all right, let's jump into it. Okay. And if I yawn, like now, I'm sorry. It's past my bedtime and, I'm getting old and that's just what happens. So, okay, write down in order the pathway of airflow from the nose to the alveoli, as well as through the mouth to the alveoli. Okay, please write using the proper medical terminology. All right, that's simple. Okay, and just so you know, it's going to eventually turn into the same pathway, right? Because we're all headed to the alveoli where the gas exchange occurs. So from the nose, we're going to go, when you breathe through your nose, that air goes through the nose into the nasopharynx, into the oropharynx, and it travels past the larynx, through the vocal cords, into the trachea. Then it breaks either to the right or left bronchus, into the bronchioles, to the alveoli. If you breathe through your mouth, then the air will enter your mouth. It's going to bypass the nasopharynx, right? Because it didn't go through the nose. So we're going to go through the mouth and go straight to the oropharynx, past the larynx, through the vocal cords, into the trachea, break off to the right or left bronchus, into your bronchioles, and again down to the alveoli where that gas exchange occurs. Okay, so I guess it's pretty similar to the Module 1 where we wanted you to follow the drop of blood, the pathway of the drop of blood. This is the same thing, just making sure that you know the pathway of air and how all this stuff works as well. Super important. Okay. All right, so looks like we've got a couple people joining us. That's fantastic. Okay, where am I? Right here. All right, let's go to number 2. Oh, goodness gracious. Please describe the airway sounds below. What causes it and give an example of each. So we've got rhonchi, rales, wheezing, and stridor. Don't forget, diminished is another airway sound. And then clear. We cannot forget clear. Clear obviously is not necessarily an abnormal sound. That's what we want to hear is clear, right? So we're going to go over these. And then I have a fairly decent YouTube video that I can share with you guys. And I'll send that out too. Okay. Just because it's kind of hard sometimes to hear every single one of these abnormal airway sounds. And I know you guys are going to hear some of them during your clinicals, but you're most likely not going to hear all of them. So I will send out that link just so you guys can have it. And you can hear what I'm talking about. So rhonchi is, and it's actually spelled R-H-O-N-C-H-I. But anyway, rhonchi is what I hear when there is obstruction or fluid in the larger airways. Okay. So the larger airways is going to be like your bronchi. Not necessarily your smaller bronchioles, but your larger bronchi, right? So I've got obstruction or fluid in there. Normally, I hear this when there's like an infection and stuff like that. You can think of it as it's junk in the lungs. That's kind of the easiest way to describe it. Junk in the lungs, right? It's going to be a coarse, low-pitched breath sound from mucus, chronic mucus in the large upper airways. Okay. Your rales, and another word for rales is crackles. So you can put, if I could, I can't right now. Oh, I can. Look at that. Ha. Oh, I'm so going to fix this spelling. There we go. That makes me feel so much better. So crackles and rales are the same thing. This is also a lower airway sound, okay? So crackles and rales are bubbly or crackling sounds that's associated with fluid in the lungs, okay? So fluid in and around the alveoli. And that's what we call, pulmonary edema. So anytime you have pulmonary edema, then you will, or anytime you hear crackles and rales, that means there is fluid in the lungs or pulmonary edema, okay? Most likely, your prime candidate that has pulmonary edema is the one that has congestive heart failure, and we'll talk about that a little bit further on into the review. But not every patient that has pulmonary edema has a history of CHF. There's other things that can cause pulmonary edema. So don't think that that's kind of like the only thing. But if you hear crackles and rales, that bubbly crackling sound, then that means pulmonary edema. If you can think of like when a fire crackles and pops, like a campfire, that's kind of what that sounds like, okay? Wheezing is another lower airway sound, and we talked about that quite a bit today when we were going over our albuterol with our pharmacology. But wheezing is a high-pitched musical whistling sound indicating constriction of the bronchioles, right? So if you have bronchoconstriction, then you will have wheezing. Okay. And again, I hear this on expiration. That's when I'm going to first hear wheezing is on expiration. You can hear it on both inspiration and expiration if your patient is really struggling, but you will never hear wheezing on inspiration by itself. Okay. Never hear it on inspiration by itself. So again, this is that high-pitched musical kind of whistling sound. It almost sounds like a harmonica, like a high-pitched harmonica that I'll hear on expiration. And that means that there's air trapping and they're using a lot of extra muscles and they're really trying to get that air out. Okay, so that's from bronchoconstriction and inflammation of those bronchioles. I will see that with COPD patients, asthma patients, patients that have bronchitis, things like that. Stridor is a sound that I hear from my upper airway. Okay, and remember, the vocal cords is what kind of separates my upper versus my lower airway. So stridor is going to be an upper airway sound that I hear. It's a harsh, high-pitched whistling sound heard on inspiration, right? So remember, stridor is on inspiration, and that indicates a partial blockage of the upper airway, okay? Whether it's croup, epiglottitis, it could be, airway swelling from anaphylaxis. It could be FBAO, a foreign body airway obstruction, right, where they're choking. But if you hear stridor, that inspiratory high-pitched whistle on inspiration, then that means that there's a partial blockage of the upper airway. And I need to investigate it a little bit more and see what it is, right? How can I manage that? Diminished lung sounds, just to kind of add that in there, diminished lung sounds is when you're really having a hard time hearing any kind of air. So just kind of keep in mind, anytime you hear rhonchi, crackles, rails, wheezing, anytime you hear this and clear lung sounds, that means you're actually hearing the air go in and out, right? If you're having a hard time actually hearing the air movement, then that's what we call diminished. Okay, and diminished is obviously pretty bad, because if they're not moving a whole lot of air, then that means they're not bringing in enough oxygen. Okay. So jumping right into our different medications, and I know that the last two classes for my UTA, and we're going to do this tomorrow at UT Dallas, but we've been hitting the pharmacology pretty hard in my rotation, just to make sure you guys are familiar with this and good with this. I really, really want you guys comfortable with your pharmacology. That pharmacology chart is due. And it talks about, mechanism of action, how it works in the body, what's the dosage, what's the side effects, what's the indication, contraindication, all that stuff. I need you to know it all, because I need you to be comfortable with how you can manage a patient. Okay. So this first one obviously is epinephrine. All right. And one of the best places that you can find this information, actually I have two places for you. Okay. We are going to go to, let me see, I think it's in your Canvas. Stand by. Let me look. Okay. So in your module 2 on your Canvas, if you scroll, we're going to look at this lookalikes study aid in just a minute. But if you look at your medications PDF right here, this right here, I'm going to go ahead and download it so I can pull the whole thing up. Has pretty much everything you need, plus a little bit extra. We've got albuterol. No, I can't change the spelling of that. Okay, albuterol, nitro, aspirin, but look at this. It tells you the action. That's the mechanism of action that I'm looking for. The indications, the contraindications, the side effects, the route, and the dose. It has all that. There's your oral glucose. There's your Narcan. There's your epi, right? There's your Atrovent that we were talking about earlier. There's your activated charcoal. Don't forget oxygen, right? Oxygen is something that you still kind of have to think of it as a medication. Okay, and I think the rest is just kind of empty. But you've got all of this at your fingertips that you literally can use to fill out that pharmacology chart. Okay, and if you don't want to use this, then you can use, and this is also available, just so y'all are aware, this is actually available on your weekly schedule. So if you were to pull up your weekly schedule, both the UTA and the UT Dallas one, it doesn't matter which one you're looking at, but if you pull up, there it is right there. So from today, or I think it's the Monday, June 16th date, there's the medications PDF right there. You can pull it up from here as well. Okay. And there's your lookalikes PDF. So they're both on your weekly schedule and in your module 2 on Canvas. But it's really, it's a great resource for you, because when you're filling out that pharmacology chart, everything that you need pretty much is on here. Okay. If you want to look in your book, which is totally fine, just remember chapter 12 is your pharmacology chapter. And they have this big old chart in here for you. Or is this a table? It's table 12-4. And if I was going to look at it, it's on page 508 and 509. But again, it's table 12-4. Okay. So let's jump into this, this information here. So epinephrine. The first thing we need to know is how it works, okay? Oh, excuse me. Actually, let's start with what it's indicated for, okay? So when am I going to use epinephrine? I'm going to use it when my patient is experiencing an anaphylactic reaction, right? So anaphylaxis. And how do we get there? Hang on, let me just kind of show you. I had this on here earlier. So if you go to your module 2, go to your module 2 in your Canvas, and you scroll down to where you see medications, the PDF file for medications right above your pharmacology chart and your emergency chart. That's the medications that I was just pulling up. Okay. And like I said, you can also find this on your weekly schedule. All right. So let's get back to this. Okay. So epinephrine, I'm going to use for when my patient is experiencing anaphylaxis. Okay. Because the mechanism of action for epinephrine is that it causes that bronchodilation and also causes vasoconstriction, okay? And if you guys remember from Module 1, epinephrine is the hormone that's released with the sympathetic nervous system. So everything that, how the body responds with the sympathetic nervous system, or when that is stimulated, is basically the mechanism of action of epi, okay? Because when epi is released, that's what happens in the body. So, but the two big things that I want y'all to think about as far as how we use it for anaphylaxis is that it combats that histamine release, right? And so when your patient has that big release of histamine and it causes vasodilation, that systemic vasodilation that puts them possibly into distributive shock, then that means, their blood vessels are too big, right? And they're having trouble breathing and stuff like that. So when I give this epi, it causes vasoconstriction and bronchodilation. So it helps them breathe, it helps relax and open up their bronchioles, and it helps to kind of get their blood vessels back under control and narrow them back in, constrict them back into a better size where the blood is moving well. So causes bronchodilation and vasoconstriction. It's indicated when we want to take care of our patients who are experiencing anaphylaxis. Okay. Oh, goodness. I'm so sorry. Contraindications of this would be if your patient has high blood pressure, if they have hypertension. Because if they have hypertension, then they're not experiencing that distributive shock, right? They don't have that vasodilation, right? So if they're not vasodilated, then they're not going to be hypotensive. So if they're hypertensive, then it's not indicated. It's not something that I want to do. Kind of shy away a little if your patient is experiencing chest pain. If they're experiencing chest pain, then maybe I need to look into it a little bit more and confirm, is this a true anaphylactic reaction, or is this something else going on? Okay, so just kind of be aware of that. The route, remember, is an intramuscular. I'm going to use that EpiPen that they have. For an adult, my dose is 0.3 milligrams, and for the pediatric, the dose is 0.15 milligrams. Now, if you do work in a system where they allow you to draw up the epinephrine out of the ampule, then that's totally fine too. And like I said, I was planning on showing you guys how to do that, but since that's not 100% across the board, as far as your like a national scope of practice, then it's really not a priority. I just need you to know the doses, and I need you to know that you're going to assist the patient's EpiPen. Okay. So again, adult is 0.3 milligrams, pediatric is 0.15 milligrams. Okay. All right. Moving on to albuterol. This is another one that we use for respiratory issues, right? So albuterol, remember, is something that we give in the nebulizer for the patients who are having issues, are in respiratory distress with wheezing. So the indication to give albuterol is wheezing, okay? Sometimes we have people say, oh, well, it's asthma or it's COPD, and there's some truth to that, but it's not just the medical condition itself, it's the fact that they're wheezing. So if you remember wheezing, when we were talking about our lung sounds earlier, if you're wheezing, that means that you're bronchoconstricted. Okay. So if your patient is bronchoconstricted and is having wheezing sounds, then I'm going to give albuterol, because its mechanism of action, how it works, is it is a bronchodilator. So it's going to open up their airways, right? If they're bronchoconstricted and wheezing, then that means I need to open them up to allow that air to move more freely through. So your dose of albuterol is 2.5 milligrams. That dose is the same for your adult and your pediatric patients, because remember, it comes in the little, we call it a bullet. I know that sounds weird, but it comes in the little, neb bullet, if you will. And I just twist the top off, put it in my nebulizer chamber, and give it to my patient. And they will breathe it in at their own respiratory rate. Okay, so 2.5 milligrams for both your adult and your pediatric for your albuterol. The route, of course, is inhalation. And they're going to breathe it in on their own. When you hook it up, or when you put it in the nebulizer, and remember the nebulizer mask, goes on their face and hooks up to oxygen, you need to hook the oxygen up to 6 to 8 liters per minute. No less than 6, no more than 8. Okay, put it on 6 to 8 liters per minute, so it will aerosolize that albuterol for your patient to breathe it in. It is a bronchodilator. And it's going to help them breathe, right? We'll talk a little bit more about asthma and COPD and some of those medical conditions when you'll use this. We'll talk about that a little bit more later in the review, but that's what we've got for albuterol. Atrovent is another, it's another bronchodilator, okay, that we use if albuterol by itself didn't fix the patient. Okay, turn my phone off. If it didn't fix the patient. So if that's the case, then second. Sorry. Okay. So you're going to give your patient an albuterol treatment in the nebulizer. They're going to breathe it in. And if they continue to wheeze, or if they have not improved with albuterol by itself, then you will give Atrovent. Atrovent, another name for Atrovent, is ipratropium bromide. There we go. Okay. So that's basically another word for it. I'll just put it like this. There you go. Okay. This is also a medication that they breathe in through inhalation. The dose of ipratropium bromide is 0.5 milligrams or 500 micrograms. It also comes in its own little bullet. And you, again, would just twist off the top, squeeze it into the nebulizer chamber and give it to your patient with the oxygen running at 6 to 8 liters per minute. This is a combined treatment with albuterol. Okay, so albuterol is by itself, and then if that is not successful in managing your patient, they continue to wheeze and continue to have issues, then you can put them on an albuterol Atrovent duo neb. Okay, where I add one albuterol and one Atrovent together to that nebulizer chamber and give it to them. Atrovent, like I said before, is another bronchodilator. It just works on different receptors. I think your albuterol is a beta-2 agonist receptors, and Atrovent works on muscarinic acetylcholine receptors. So it works a little bit different, or it affects different things. It still hopefully gives you the same effect of bronchodilation, but is going to work on some different stuff in there. It also helps to dry up the secretions that your patient may be experiencing, because a lot of times those asthma and COPD patients who are wheezing, they also have secretions in their bronchioles that add to the distress. So Atrovent will help to clear that up, or help to dry that up. Okay, moving on to naloxone, also known as Narcan, right? All right. So Narcan is indicated when you have a patient with an opioid overdose and they are experiencing respiratory depression. Okay, so I want to give Narcan or naloxone. It's the same thing. It's just a different name for it. I want to give that when my patient is experiencing respiratory depression from an opioid overdose. Very specific. This is opioid only. Okay. That respiratory depression is going to be where they're really not breathing very well, if at all. Their respiratory rate is super low. Their tidal volume is super low. I mean, they're barely moving any air, right? So that's when I need to give this Narcan, because the Narcan actually reverses the effects of the opioid. Okay. So it's going to reverse that respiratory depression that occurs from the opioid overdose. The way you're going to give it is intranasal, right? It goes up the nose. You're going to use that MAD device, that mucosal atomizer device. It's a little cone-shaped attachment that you put on your Narcan, on the syringe of Narcan, and you shoot it up their nose. Okay, and we discussed it in class today with UT Arlington. We'll discuss it in class tomorrow with UT Dallas. Okay, so y'all will be able to play with that. But the dose is 2 milligrams. That's your total dose, and you want to deliver half in each patient's nostril, or in each nostril. Okay, so I'll do 1 milligram in the right side, 1 milligram in the left side. And I do that so I can kind of disperse it a little bit more evenly throughout their mucosal membranes, so it's absorbed rapidly, and I can get pretty much all of it into my patient. Okay, so this is an intranasal route, 2 milligrams, 1 in each nostril. And I use it to reverse the respiratory depression on my patients with an opioid overdose. Other ways that you can, or that you need to manage that patient with an opioid overdose, super important, okay? You have to bag them. You have to manage their airway, because if they're only breathing, 3 or 4 times a minute, and you're waiting for your partner to administer Narcan, then you're not managing your patient. You're not managing that life threat. When you walk in and they're unconscious, unresponsive to you, possibly, they're going to be pale, because they're only breathing a couple of times a minute, then you have to manage their airway. You got to breathe for them. Get that BVM out, head tilt, chin lift, and assist their ventilations while your partner pulls up the Narcan. When the Narcan is ready, take the mask off their face, administer it intranasal, and then get ready, because they're going to wake up pretty abruptly. Okay, because this Narcan actually, when we say it reverses it, it truly does. Okay, it truly reverses that and wakes them up within at like 10 seconds at the most. When they do wake up, they'll be vomiting. Okay, they'll wake up vomiting. So have your suction ready for additional airway management. It's a pretty intense reversal, so that's why their body wakes up vomiting. Okay. All right. Let's see here. Oral glucose, and as you can see, not everything is on here. I mean, technically, there's a lot more on here as far as... So there's oral glucose. We'll go over oral glucose next. Oral glucose, the indication for this is going to be hypoglycemia. Okay. And I know that my patient is hypoglycemic, one, because how they're responding, or how, what's their level of consciousness and what's their complaint and all that kind of stuff. But also because I got that glucometer out and I checked their sugar, right? And if they have low blood glucose levels, lower than what is normal, for them, and they're having effects, so they're what we call symptomatic for hypoglycemia, then I definitely need to treat that if I can. Okay. The first thing that you're going to see on a patient experiencing hypoglycemia is you're going to see confusion, because, and I know y'all will roll your eyes when I say this, but the brain needs 2 things, right? It needs oxygen and glucose. If it doesn't have either one, then your brain's not going to work appropriately. Okay, so if you're low in glucose and your brain isn't getting the nutrition that it needs to work appropriately, then you're not going to be alert and oriented. You're going to start to have confusion. And then as your hypoglycemia continues and it gets worse, then you'll eventually lose consciousness. Okay, so oral glucose I use for a patient who is hypoglycemic. Now, because oral glucose is an oral medication, then that means that they have to be awake enough to protect their own airway and swallow in order for me to administer this. So some contraindications, because right now we haven't really talked about contraindications about, these other ones. There is no contraindication to epi, because epi is a hormone that we normally, put off in our body. So there's really no contraindication to it, unless, like we said, they're hypertensive or they're not actually showing the true signs of anaphylaxis. So it's not indicated to give. Albuterol, if their heart rate's a little high, got to be careful with that. Narcan, there's really no contraindication to Narcan, or at least not in the emergency setting. But oral glucose, there is. Okay, so the reason why we want to know these contraindications is because if you get on scene of a call and that patient is unconscious and unresponsive with low sugar, you know how to fix that. You want to fix it, but you can't because your patient is unconscious. Because the contraindications to oral glucose is your patient has to be awake. So if they have a decreased level of consciousness, okay, and think about that AVPU, right? If they're verbal or they're responsive, only to painful stimuli or something, to where they cannot control their own airway and they can't swallow, you cannot give oral glucose. You can't just squeeze the stuff into their mouth and hope for the best, right? So they have to be awake enough to control their airway and swallow. This is an oral medication. It can cause some nausea, vomiting. It can. But in the emergency setting, if your patient is awake and alert enough, then we give it. Okay. The dose, the adult dose, is 15 grams. Okay, so a lot of times we say 1 tube, but I want you guys to know the actual unit. So this is 15 grams. Your pediatric dose is the same. Okay, 15 grams. That's what I want you to know. Patient must be awake, have control of their airway. They must be able to follow commands because they have to swallow. All right. After you give oral glucose, you're going to reassess their blood sugar. So you'll poke their finger again and make sure that, their sugar has gone up, their blood glucose levels have increased, and kind of go from there. And we'll talk a little bit more about diabetic patients and stuff and the treatment for that in a minute. You've got 2 more medications on here, or 3 more actually, because I do want to talk about activated charcoal. I do want to talk about aspirin and nitro. Those are, and it drives me nuts that it's not on the list, but we're going to talk about it anyway. So let's talk about activated charcoal real quick. Activated charcoal is a oral suspension. So you give it by mouth. And the indication would be when my patient has ingested some kind of solid, like pill form, and they have an overdose from that. Okay, so if someone decided to take an entire bottle of Tylenol or empty their medicine cabinet and take all the pills in their medicine cabinet, then this is when I would want to give activated charcoal, because its mechanism on what it does is it's going to coat or encompass or enclose, whatever word you want to think about, but it's going to surround those pills, which inhibits and prevents it from being absorbed into the body. Okay. Your dose is 1 to 2 grams per kilogram. So this is a weight-based dose, and you've got to know the patient's weight. Okay. Keep in mind that every time, right over here, in the States, we think of pounds. We don't measure things in kilograms. It's not what we normally measure things. We measure things in pounds. So if your patient says that they weigh however so many pounds, then you have to convert it to kilograms for this medication. And you have 2.2 pounds per kilogram. So just kind of keep that in mind. I will not give you any kind of math problems on this exam, but just make sure that you know that you have to convert your patient over to kilograms as far as weight is concerned. So activated charcoal, 1 to 2 grams per kilogram. It is an oral suspension. Because it's oral, your patient does have to be awake enough to swallow and follow those commands, to kind of manage their airway. Okay. Aspirin and nitro, these are the two medications that I want to give my patient who's experiencing chest pain. I also want to give oxygen, but we'll talk about oxygen at the end. So aspirin, the indication of aspirin is cardiac-related chest pain, okay? So and the reason why I say cardiac-related chest pain is you can have musculoskeletal chest pain also. Really assess your patient though, because if they say, oh man, my chest is hurting, then I don't want you to disregard that. If you think it's trauma, I really want you to assess your patient and just make sure that you have a good idea about what's going on before you say this isn't cardiac related, because it still could be, So get a good history of the event and get some good questions asked with that. But this is cardiac related chest pain. The aspirin itself, the mechanism of action in aspirin is it is an antiplatelet. Okay. And just keep in mind that those coronary arteries, those are the vessels that feed the myocardium, right? Those are the vessels that deliver the blood and the oxygen to the heart muscles, so it will continue to work appropriately. When there's a clot in one of those coronary arteries, well, then that's when you start to have this chest pain. Okay, because if there's a clot, then that means I have diminished blood flow to any tissue that's distal to the location of that clot, and that blood vessel is no longer supplying the appropriate oxygen to that tissue. So your patient starts to experience chest pain. When I give aspirin being an antiplatelet, platelets are in your blood, and whenever they're passing by this clot, they naturally will want to stick to it and make the clot bigger. But if I give my patient aspirin, an antiplatelet, it basically makes your platelets slippery to where they skip just past it and they do not stick. So get that aspirin on board pretty quickly. The contraindications to aspirin would be if your patient is allergic to it, or if they're having an active bleed, internal bleeding, such as an active GI ulcer or things like that. You don't want to be, given aspirin to someone who has an internal bleed, because it'll just make it worse. It'll make that bleed worse. So the indication is cardiac-related chest pain. Contraindications are going to be the most obvious one, which is, an allergy to it. And then again, some kind of internal bleeding, those active ulcers, active bleeding internally. The dose, your adult dose, is up to 324 milligrams. Remember, we use the low dose aspirin, and those low dose aspirin, each one of those tablets is 81 milligrams. So you would want to give 4 of those 81 milligram tablets to your patient. This is an oral medication as well, so they have to be awake enough to follow commands and chew. It's a dry chew, and I say that because we don't give them water with it. Okay, so they can't wash it down with water or anything like that. It's a dry chew, and we go from there. If I wanted to give 324 milligrams, then I would give 4 of those 81 milligram tablets, okay? Your pediatric dose does not exist because we do not give aspirin to kids. Okay, we don't give aspirin to kids. Okay, let's see here. Nitro. Nitro is the last one I want to talk about. And nitroglycerin is also something that I want to give for cardiac-related chest pain. Okay, so the mechanism of action of nitro is that it's a vasodilator. Okay, so if you can envision that coronary artery that has a clot in it, right? A big old clot that has kind of grown over time from multiple things, cholesterol levels, atherosclerosis. Atherosclerosis is never good, right? It's something that definitely will cause heart attacks and strokes and things like that. But envision a pipe that has a clog in it that's clogging up maybe half of it. Okay, so only half of the lumen, or the opening, is getting through as far as blood is concerned. I've given that aspirin to make sure that the clot doesn't get any bigger, but now I want to give that nitro to make the pipe bigger. I want to enlarge it, vasodilate that coronary artery to increase the blood flow. Okay. So when you give your nitro, it's going to vasodilate, but it doesn't only vasodilate your coronary arteries. Remember, it vasodilates everything in the body. There's no way for me to only do the coronary arteries. So you do have a couple contraindications with your nitro. You got to be careful with this, okay? The first thing is that you have to have a good set of vitals on your patient. Aspirin, you don't necessarily have to have vitals. You just want to make sure your patient isn't internally bleeding and doesn't have allergies, so I can go ahead and give my aspirin. But you have to get a full set of vitals for your patient before you give them nitro, because that blood pressure is super important. The nitro, its mechanism, that vasodilation, is going to cause their blood pressure to drop. So I have to make sure that their pressure is good before I give them nitro. Okay. And you want to give them, let's see here. Your book says that your nitro needs to be a systolic of at least 100. I always go by systolic of 90. Okay. Your test is not going to be, it goes by 100, so you should be fine. But you'll just hear me say systolic of 90. So you need to make sure you have a good systolic blood pressure of at least 90. All right. Before you give nitro to your patient. If their systolic is below that and you give them nitro, it's going to cause vasodilation. It's going to drop their blood pressure. And now your patient will not be perfusing, or they won't be perfusing well. And you'll have a lot more problems on your hands, okay? Because they won't be moving the blood, right? So confirm you have a good blood pressure. Okay, systolic, like I said, your book, systolic at least 100. Okay, confirm you have a good blood pressure and good set of vitals before you give it. You also have to watch for any other medications that your patient may have taken in the last 24 hours that may interact with the nitro. Okay, specifically, we worry about those phosphodiesterase inhibitors. Okay, specifically your erectile dysfunction meds like Cialis and Viagra. If your patient has taken those in the last 24 hours, then their blood vessels are already vasodilated, okay? And if I give them nitro on top of that, right, if I put nitro into their system now, it's just gonna open up their blood vessels even more and plummet their pressure. So I really need to be proactive in my assessment before I just give them nitro. So the indication is cardiac-related chest pain. The contraindications are your blood pressure, right? So hypotension, if they're below 100 systolic, or if they have erectile dysfunction meds in their system from the last 24 hours, okay? So you have to ask your questions and you have to talk to your patient. The way we give this, or the route of administration, remember, is sublingual. So this is under the tongue. Oral glucose and activated charcoal and aspirin are all oral medications that, aspirin you chew up and swallow, oral glucose and activated charcoal you swallow. But nitro, although it is an oral medication, it's specifically sublingual. Okay, so it's different from those others. It's sublingual. It goes under the tongue. You can use either a tablet or a spray. Okay, the spray, just tell your patient, take the tip of your tongue and touch the roof of your mouth. I'm going to spray right here under your tongue. You have a lot of blood vessels close to the surface of the skin underneath your tongue. Okay, and so it absorbs pretty rapidly. If you use a tablet, you just pop one little tablet underneath their tongue. It's an ODT, an oral dissolving tablet, so it will dissolve and get into their system. Your adult dose for nitro is 0.4 milligrams. So one spray or one tab is 0.4 milligrams. And then we do not give nitro to kids. Okay. Aspirin is a one-time thing, right? So I'm going to give 324 milligrams and be done with it. My nitro, I can repeat that dose if I need to, because if my patient still continues to experience chest pain, then I can give more than one dose. But you need to reassess your pain scale, reassess your vitals before you give another dose of nitro, right? Because I don't want to have that first nitro I give them drop their pressure below the threshold to where if I give them a second one, it's going to cause problems. Okay, so always make sure to reassess your patient before you give them additional doses. You do have some side effects of nitro. One of the big ones is a headache. Okay, obviously the other one is hypotension. We know that because it causes vasodilation. But just keep in mind, you may have a patient who says, that they don't want it or they're allergic to it because they get really bad headache, and that's not an allergic reaction. That's actually a side effect. Okay, so really know the ins and outs about your pharmacology. So some of the things that you guys will hear me say in class is, you can have a patient who, just like the oral glucose, right? They're unconscious, unresponsive. You get on scene, you're managing your ABCs, and you get a blood sugar because you know that you want to assess their glucose levels because low glucose, affects the brain's function. You find that they're hypoglycemic, but you cannot give oral glucose because they're unconscious. That chest pain patient that's experiencing chest pain who is allergic to aspirin and has a blood pressure of 80/40, you can't give them aspirin and you can't give them nitro. Right. So you want to, because that's, within your guidelines and within your protocols and how we manage those patients. But that specific patient cannot get the treatment that we would normally give. So that's why, on day one, when I'm talking about how every patient is different and you have to know why, not just what we give, but why we give it and how we give it, then that's the important piece. Now, as far as oxygen is concerned, oxygen also is a medication. I really need you guys to understand that. Oxygen is a medication. If your patient has a pulse ox reading above 94%, then they do not need oxygen, okay? If it's below 94, then I need to go ahead and give them oxygen, okay? So again, I don't just give it to give it, right? It's not just something that I'm gonna do just to do. There actually has to be a need for oxygen, okay? And remember, you have your nasal cannula that can give it 1 to 6 liters per minute. You have your non-rebreather that can give it 10 to 15 liters per minute. And then you have your BVM that will be 15 and above. If I use my nebulizer at 6 to 8 liters per minute, that means I'm giving another medication, right? So I don't want to talk about, nebulizers administering oxygen because I use my neb for other things. All right, cool. Moving on, let's go to patient assessment, which this should be a pretty good review of you for you guys of your module 1. Okay. So because remember, your patient assessment is all about primary assessment and seeing what we've got. So according to patient assessment, please list in order the steps to what you would address first before moving on to the next one. Please give examples of what you would be looking for each one. Okay, so primary assessment. This is after the scene size up. Scene size up is where I'm looking at the scene and making sure it's safe for myself, calling additional resources and doing all that kind of stuff. The primary assessment is when I actually focus in on my one patient or my patient, okay? So the primary assessment, first off, before I even get to 1, 2, 3, I'm looking at their level of consciousness, right? I'm looking at their level of consciousness. Are they awake? Are they alert? Are they unresponsive? Or do they respond to verbal stimuli or painful stimuli, right? So AVPU, AVPU, make sure you know that. Then I'm looking at my life threats. If I have a medical patient, I'm thinking about ABCs for airway, breathing, circulation. Is their airway patent? Is it open? Do I need to suction? Are they gurgling? Do I have secretions or blood? Do I need to open their airway with a head tilt chin lift and then suction it out, right? Things like that. Breathing, are they breathing appropriately, right? Y'all know already from module 1 what is considered adequate breathing, right? Look at the rate, look at the tidal volume, look at their mental status. If they have good mental status and good skin with good rate and tidal volume, then they have good breathing, right? Another thing that we look at with breathing is if you get on scene and they're struggling, they've got respiratory, signs of increased work of breathing and they don't look good, then just pop on some oxygen. Just go ahead and give them some oxygen. If they are looking like they're struggling, just do it. And then the third one, of course, is your circulation, right? ABC, circulation. Control any major bleeding, which we'll talk about a lot more in Mod 3. And then, look at the skin, the color, the temperature, the condition of the skin. Are they dry or diaphoretic? And of course, what is their pulse? What's their pulse? Where did you find it, right? Did you find it at the radial site? Did you only find it at the carotid site? Where did you find it? And then, of course, what is the rate? Okay. If I have a trauma patient, then I'm going to be looking at X ABCs. X stands for exsanguination. Any trauma patient, I have to control major bleeding first. Then I go into airway breathing. Okay. But again, we'll talk about that a lot more in Mod 3. So primary assessment, level of consciousness, and then life threats. ABCs for medical, X ABCs for trauma. Your vital signs is something that I'll get during my secondary assessment and my history taking when I'm asking my sample questions and all that good stuff. If I have a patient with a chief complaint of pain, then I'm going to be asking my OPQRST questions, right? What's the onset, provocation, what makes it worse, what makes it better, all that. Okay. But vitals are really, really important. And I find it kind of funny sometimes because I know that y'all understand what I'm telling you, but when you do your clinicals, it just makes it that much more real. And every semester I have students come up to me and they're like, man, I never really realized just how important vitals are. So it's really important, excuse me, that you get an accurate set of vitals. So knowing how to get a good blood pressure, knowing how to auscultate that blood pressure, knowing how to palpate that blood pressure is really important. Heart rate and respiratory rate. That is a full set. Blood pressure, heart rate, and respiratory rate. For an adult, you want your systolic between 90 and 120. That is what's considered normal. And remember, your pediatric systolic is going to be less than that. Let me pull this up from our exam 1 review real quick. If you want to do a quick review of your vitals, then remember that your blood pressure you can find in chapter 10 at table 10-7, and that will go through all of your different blood pressures and what's appropriate for the different age groups. Your heart rate, remember what is normal for an adult is 60 to 100. Anything less than 60 is considered bradycardia. Anything over 100 is considered tachycardia, right? You want your adult patient, to be between 60 and 100. That's their normal at-rest heart rate. For your kiddos, however, they're going to be higher, and that's normal for them, right? So it's normal for kids to have a lower blood pressure, but it's normal for them to have a higher heart rate. Okay. And again, if you want to take a look at what's quote unquote normal, go back to chapter 10 and look at table 10-6 for your heart rate. Respiratory rate is another one, super, super important. You may have a patient, I'm kind of throwing this out there, you may have a patient who refuses for you to take their vitals. They don't want you to touch them. So you don't even get a chance to feel a radial pulse or do any of that kind of stuff. But you can still get a respiratory rate because you can still look at them, right? So just remember, your normal adult rate is 12 to 20. Anything less than 12 is that bradypnea. Anything more than 20 is tachypnea, right? Your kiddos will have a higher respiratory rate, and that's inherent and okay for them, okay? And again, looking at chapter 10, if you go to table 10-4, that gives you their respiratory rates for pediatrics and toddlers and stuff like that. Okay. SpO2, anything less than 94% needs oxygen. Okay, anything less than, I'm going to say that again, anything less than 94% needs oxygen. Keep in mind that that SpO2 sensor goes on the finger, goes on a digit, right? Finger, toe, something like that. When I have a patient that broke an extremity, maybe they broke their leg, I'm going to put that pulse ox on their toe just to kind of confirm and make sure that we have good circulation distal to the break on that extremity, okay? But watch for patient movement. If your patient is moving around a lot, it can affect the reading on your pulse ox. Watch also for hypotension. If your patient has low blood pressure, then that means that, the perfusion isn't getting all the way out, or it's possible that the perfusion may not be getting all the way out to, their fingertips and their toes and stuff like that, where that pulse ox is. Watch for hypothermia, because if your patient is vasoconstricted from hypothermia, then what happens is, you vasoconstrict, and it kind of keeps that blood closer to the core. And so that pulse ox will be inaccurate because you don't have good blood flow to the, to the tips of your digits. Nail polish will also do it. Your SpO2 sensor is an infrared sensor, and it cannot go through nail polish. So just kind of be aware that when you put it on someone's finger, if they have nail polish or fake nails for that matter, it's not going to read. You can, however, put it sideways instead of clamping down on them. On the top where the nail bed is and on the bottom where your fingerprint is, you can kind of turn it sideways and just have it clamped sideways, hitting the sides, the medial and lateral sides of your finger, and it will still read because there's no nail polish on those sides. Okay, so you can kind of sometimes just shift it over. But pulse ox isn't always, what I'm trying to illustrate here is pulse ox isn't always as accurate if you have different conditions and stuff going on. If you're not sure about perfusion, do a cap refill. If they've got good cap refill, then your pulse ox is going to be pretty accurate, unless your patient's moving around a whole lot and they just can't sit still. Okay. Your secondary assessment. Again, I'm looking at, I'm asking my questions, right? I'm really not doing the conscious versus unconscious. That is actually more for my primary assessment. So kind of strike through that, but we're doing our sample here. Okay. Now, I guess what we can figure is if your patient is conscious, then I'll be able to ask my sample questions. If they're unconscious, then I can't, right? So if they're unconscious, then I'm kind of left with a patient where I'm trying to just kind of get my information from what their body tells me, what I see, what I find on their body as far as a physical exam, as far as my vitals and things like that, and then just what do I see in the environment around me. But if they're awake and they're able to answer my questions, then I'm going to ask them sample, right? And this is a great acronym to kind of remember all of the things that I need to ask them. Remember, S stands for signs and symptoms. Okay. Remember, a sign is something that you see, you can figure it out on your own because you see it, you hear it. A symptom, however, is something that your patient tells you, right? So you need both. When you talk to your patient, you're not going to just walk up to them and say, hello, ma'am, how are you doing today? My name's Stephanie. I'm a paramedic. What are your signs and symptoms? Because they have no idea what you're talking about. Okay, so make it simple and just ask them, what's bothering you today, right? And they're going to tell you all about their symptoms. Okay, so what do you see, and then what can they tell you about what's bothering them? A stands for allergies, and this is allergies to medications. And I know in class I've talked about this a couple of times, but make sure that you don't forget that there are other over-the-counter medications that patients can take, or over-the-counter supplements or herbal remedies or things like that. So if you just kind of if you, I don't know what I'm trying to say here. I promise I'm not having a stroke. If you only ask them, do you take any prescribed medications, then you've narrowed the question too much, right? That's what I'm looking for. Don't ask them too narrow of a question. Ask them, do you take any medications on a regular basis? If they say no, kind of follow it up with any vitamins or supplements or anything that you might get or anything that you might take that's not prescribed by a doctor. Okay. So again, well, I guess I'm talking about allergies anyway. You know what I'm talking about. Do you have any allergies to any medications? And then the medications is, do you take any medications on a regular basis? Okay. And don't forget other things. Allergies, if they say they have an allergy to something, then ask them, right? If they say, oh yeah, I can't take sulfa drugs, then ask them what happens. Oh, I swell up. I can't breathe. All right. That is an absolute allergy. But if they tell you something different, then like what we said before when we were talking about our medications, our pharmacology, it's very possible that they're thinking about a side effect. So if they say they have an allergy, then just kind of validate it, kind of confirm, ask a couple more questions and see what happens. M, medications on a regular basis. We just covered that. Don't narrow it to only prescription meds. Do you take any other meds? Do you take any supplements? Do you, self-prescribe things to you, And then P stands for past medical history. Past and pertinent medical history. Do you have any medical history? Do you see a doctor for any medical conditions? If they say no, then you should be okay. If they take 5 medications and they don't have any past medical history, then maybe you need to ask it a little bit differently and say, well, I see that you take these medications. Why do you take them? Oh, because I have X, Y, and Z. Okay. That kind of stuff. L stands for last oral intake. When did you last eat? When did you last eat anything? When did you last drink anything? It may play into their chief complaint, especially if they're having a possible allergic reaction or some kind of reaction, maybe nausea, vomiting, or something like that. It's very possible it could be the cause. But at the very least, it gives you another piece of the puzzle, and it allows you to get a whole view. If this patient is going to end up going to surgery for whatever reason, whether it's trauma, medical, whatever, then that last oral intake is very important to the surgical staff when they're considering surgery. So it's a good piece of information to have. And then E stands for events leading up to, right? What was going on when this happened? Okay, so events leading up to. Well, ma'am, what were you doing when you started having shortness of breath? Okay, if you ask, they will tell you. Okay, what was happening? Now, in some classes, I know I've talked to you guys about, sometimes you may have to dig a little deeper. Okay, so sometimes it's not what were you doing immediately before this happened. Maybe it's, well, how did you feel yesterday? How have you been feeling over the last couple of days? Have you had any issues with this over the last couple of days? Right? That kind of thing. So events leading up to, get some good information from that. Your sample, super important. OPQRST, I don't know if we talk about OPQRST in here. I can't remember. No, we don't. So just make sure you know your OPQRST, because that is important. We need to be getting that information, especially when our patients have complaints of pain, because that's a really great way to assess them. Really great way to assess them. You have that pain scale, that number that they can give you. And so when you reassess after you've managed your patient, you may have just given them a cold pack or put them in a position of comfort. But it's very possible that you have now decreased their pain with that simple maneuver. And now their pain used to be a 5, but now it's a 2. So reassess that stuff, right? Okay, number 5, explain the difference in compression to breath ratio for adults versus pediatrics. What changes when you have 1 person versus 2 person? All right, so this is a review of BLS, right? Your adult patients is always going to be 30 to 2. Remember, 30 compressions to 2 ventilations. It doesn't matter if you are by yourself or if you have a 2 or more person group with you. Your adults will always, always, always be 30 to 2. Your pediatric patients, if you are by yourself, you will perform a 30 to 2 compression to breath ratio, compression to ventilation ratio. If you have help, if it's more than just you, so if you have a 2 person or more, then it is now a 15 to 2 compression to ventilation ratio. And remember, that's because most kiddos go into cardiac arrest from respiratory issues. And so we want to actively replace the oxygen that they lost and hopefully address the cause of the arrest. So adults, always 30 to 2, doesn't matter how many people are on your scene. Pediatrics, if you're by yourself, 30 to 2. And remember, pediatric is a child and infant. Okay, so it's both. 30 to 2 when you're by yourself, but 15 to 2 when you have help. When you're reading your question, whether it's my exam or your National Registry exam, the first thing that should jump out at you is the age of the patient. Okay, so if it's a 38-year-old, that's, you have an adult and you know what's normal for a 38-year-old. If you have a 6-month-old, then that's not an adult, that's an infant, right? And you should know what are the normal vital signs. You should know this stuff just based on that one piece of information. Those are things I want you to start thinking about based on that one piece of information that you get from your question. Okay. All right, so let's talk about some respiratory emergencies. First one we're going to talk about is COPD. All right, so COPD stands for chronic obstructive pulmonary disorder. You can think of COPD as kind of an umbrella term where we have two branches underneath it. Okay, one is emphysema and one is chronic bronchitis. Something about COPD, though, when we say chronic obstructive pulmonary disorder, chronic means that this has been going on for a while, okay? So chronic obstruction of the airflow that interferes with their patient's normal breathing. This is not fully reversible. It's definitely something that once you have it, you just kind of deal with it the rest of your life. And a lot of times your patients, when they're struggling, they're going to be using a lot of accessory muscles to breathe, okay? So COPD, chronic obstruction, it develops over time, most likely after prolonged exposure to smoking, like inhalation of toxic gases or particles and other irritants that bother and irritate the lungs, okay? So COPD is not something you normally would see in kids. COPD is something that you would see in your adults and older adults. So kind of keep that in mind. Okay. So emphysema and chronic bronchitis. So let's talk about those. Okay. We're going to break both of those down. So emphysema. This is the most common form of COPD. It is often caused by smoking. All right. Emphysema is the destruction of the walls of the alveoli. Okay, so super important to know this. It's the destruction of the walls of the alveoli. The alveoli collapse. Okay, and when they collapse, that disrupts the gas exchange, right? Because that's where my gas exchange occurs, is in the alveoli. Well, if they're collapsed, then it's not going to work very well because the surface area is decreased. If you think about that cluster of grapes and you think about the grapes or your alveoli, you want them plump and full and all that kind of stuff. If you've got those shrivelly, gross looking grapes, well, first off, you're not going to eat them, right? But if they're shrivelly, then that means that the surface area is not as much, right? And so if that was an alveoli and it was all collapsed and shriveled, then you're not going to have good, adequate gas exchange out of that alveoli, right? So emphysema is the destruction of the walls of the alveoli where they collapse. We also lose elasticity of our lung tissues, and so they're going to have that air trapping, okay? The emphysema patient is what we call a pink puffer. Okay, we have a pink puffer. They're going to be thin with this barrel chest appearance. They will have a non-productive cough. So we said emphysema is most often caused by smoking. If you guys, it's going to sound terrible, but if you've heard the smoker's cough, you know what I'm talking about. It's non-productive, which means it's not bringing up any mucus or anything like that. It's just a gross, rattly cough, okay? Your patient will also have that prolonged exhalation because of that air trapping in their chest. Then that means that they're going to be trying harder to exhale, or they're having to try harder to exhale to get the air out. So that phase is going to be longer than the inhalation phase. They'll most likely have some diminished breath sounds with wheezing and rhonchi. Okay, wheezing from bronchoconstriction and rhonchi from some junk in the lungs. That's your emphysema. Your chronic bronchitis, I want you to think about the word bronchitis, okay? That's a medical term right there. That is inflammation of the bronchioles, okay? So emphysema is a problem with the alveoli. Chronic bronchitis is inflammation of the bronchioles, okay? They're both forms of COPD, but they affect different parts of the lungs. Your chronic bronchitis, this is inflammation, swelling, and thickening of the bronchi and the bronchioles, which blocks the airflow to the alveoli. You're going to have also excessive mucus in those bronchioles. Yay for mucus, right? Your chronic bronchitis, these guys are your blue bloaters. So you've got emphysema, which is your pink puffers, and they have that thin barrel chest appearance. Your chronic bronchitis are your blue bloaters. They're typically overweight, chronically cyanotic, okay? So their skin is going to basically be a little bit cyanotic. And their cough is productive, though, because they have that excessive mucus. So when we say productive, it means it's bringing up stuff, right? You're going to hear wheezes and crackles, maybe some coarse rhonchi. Okay, both of these are going to have wheezing. Both of these could possibly have rhonchi. Okay, so both of these could possibly need albuterol, right? Or at least that. So make sure you know the two distinct disease patterns of COPD: emphysema versus chronic bronchitis. Okay. So let's talk about the hypoxic drive. I know we discussed it briefly in module 1. Okay. But this is really when you need to think about it, because we're talking about our respiratory emergencies. So if you remember the thing that, or the trigger which causes us to breathe is excess amounts of CO2 in our system, right? That's what causes us to breathe. The hypoxic drive is normally something that goes into effect when you have a patient with chronic lung diseases where they have difficulty eliminating CO2 from their system. So remember that prolonged exhalation phase I was talking about with my COPD patients? So they're having difficulty eliminating or blowing off that CO2. So they will have higher levels of CO2 in their body, and their body gets used to those higher levels. And the brain basically switches from recognizing the high levels of CO2 to trigger the breathing. And now they're recognizing low levels of oxygen to regulate their breathing. That's what the hypoxic drive is. Okay. How do you treat COPD? Well, you're going to do ABC management, because we do that for everybody, right? Airway, breathing, circulation. This is a respiratory issue, so definitely watch that airway and that breathing, right? So do that airway management if you need to, suction out if you need to, put them on oxygen if you need to. If they're wheezing, give them albuterol. And if albuterol isn't working and your other, management techniques are not working, then you could possibly put your COPD patient on CPAP. Okay, because remember that CPAP is used for anyone with difficulty breathing, as it maximizes that gas exchange, right? Okay. Pneumonia versus bronchitis. So let's talk specifically about these two. So pneumonia is an infection. It's an infection in the lungs, okay? It affects the gas exchange at the alveoli because the alveoli is kind of, this is rather gross, but the alveoli is kind of covered with or surrounded by pus and dead cell tissues or dead tissue cells and things like that, okay? It's an infection in the lungs caused by bacteria or virus. Most often it begins as something else, like an upper respiratory infection or a cough or just like your common cold, and it can develop into pneumonia. Okay. When you listen to lung sounds, and I really want you to think about your auscultation sites, when you listen to your lung sounds, listen to all of them. Too many times do I see people only going for the front or anterior top lobes, and they listen to the right, listen to the left, and they go, yep, you're good. And I'm like, well, hang on, I literally have 6 more sites you need to listen to, right? Because you need to listen to lower anterior right, lower anterior left, and then the back. You got to listen to the back. Okay, listen to all those lobes, because hopefully pneumonia is only in one spot, right? You only want pneumonia to be in like one little spot of your lungs. You do not want it to be in your entire lung. So definitely make sure you're listening to all your different sites. And if you start to hear sounds in different places, then you have, maybe they're clear in the upper right and the upper left. Maybe they're clear in the lower left, but they're diminished with rhonchi in the lower right. That's where your problem is. Okay, so you really need to listen to all your sites. Let's see here. Other things that you'll see with pneumonia, because it is an infection, then you'll most likely have an elevated temperature. Remember, they'll have a fever. They'll feel weak. They'll feel tired, shortness of breath. They will have a productive cough with, and this is important, with yellowish greenish mucus, and basically just gunk coming out of them. Okay, because that's the grossness. That's the infection. That's gross. They're going to have a history of an illness. So when you're talking about your sample history, the events leading up to, how have you been feeling the last couple of days? Well, I've kind of had this cough for about, a week and a half, and I thought it was going to go away, but it hasn't. And now I spiked a fever, and now I have this, and now I have this, and you're going to get the progression of it, right? Crackles or rhonchi on that one side or the affected side, unless they have bilateral pneumonia, that is possible where you can have pneumonia on both sides, right? But like I said, listen to your sites. Also think about diminished lung sounds. So diminished, crackles, rhonchi, things like that. Junk in the lungs. And they'll be cough. If they're coughing up anything, it'll be green. This is important. It'll be green. Now, my favorite color is green, okay? And that's great. However, if you ever see green coming out of a person, it is not a good thing, okay? So if they're coughing up green gunk, that's not good, okay? That means they've got an infection in their lungs. If they're coughing up green stuff and they have a fever, they've got pneumonia. Simple as that, okay? How do you treat it? Support those ABCs, airway, breathing, circulation. Give them some oxygen. They probably need oxygen. And get a good history and get them to the hospital, because that patient needs antibiotics, and we don't carry antibiotics on the ambulance. Okay, so we need to get them to the hospital for that definitive treatment to manage the infection that's causing that pneumonia. Now, bronchitis, we kind of talked about bronchitis already, but remember, bronchitis, that's inflammation of the bronchioles, right? So they will have a chronic cough and productive sputum, but that's clear. Okay, so make sure that you understand bronchitis is clear mucus that they cough up. Pneumonia is greenish mucus, okay? Big difference. Those are like the red flags, okay? Bronchitis will also have wheezing, and there'll be tachypnic with that cyanosis, right? That chronic cyanosis from the blue bloaters, right? Inflammation and swelling of the bronchi. Obviously, that's what that is. And you're going to manage it just like we said earlier with that COPD. ABCs, airway management, give them oxygen, albuterol if they're wheezing, possible CPAP. Okay. Let's see here. Yeah, we'll go into congestive heart failure later. Okay. So seizures. So this is going to be neuro stuff, okay? Switching gears over to some neuro. Name and explain each stage of a seizure. So this seizure that this question is asking about what we call the generalized grand mal seizure. Grand, G-R-A-N-D, dash mal, M-A-L, which means bad, seizure. Grand mal seizure. You have 4 distinct phases, okay? The first phase is your patient's loss of consciousness. Okay, and we call this, this is a grand mal seizure because it involves both hemispheres of the brain. And because it involves both hemispheres of the brain, then your patient will have a loss of consciousness. There's other seizures that they can have that patients can experience. There's petit mal, which is your smaller ones. There's Jacksonian seizures. There's all different kinds of seizures. But it truly depends. If you really want to think about this, a seizure is, your intermittent, neuro activity in the brain, right? Just uncontrolled, chaotic neuroactivity in the brain. And if that activity encompasses both hemispheres or crosses that corpus callosum that connects your hemispheres together, then your patient will have a loss of consciousness. Anything else that's in one side or the other, they won't. But this grand mal seizure, when they lose consciousness, is because it's their whole brain. So step 1 or stage 1, loss of consciousness. Stage 2 is what we call the tonic phase. This is when the muscles will go rigid. Okay, it's only going to last a couple of seconds, but that muscle rigidity, tonic phase. Your third phase is the clonic phase. And this is going to be that constant muscular contraction and trembling that we see with their arms, moving up and down and things like that. So that muscular contraction, this will last a lot longer than the tonic phase. It can last, a couple minutes, right? Your patient may bite their tongue. They might have urinary or bowel incontinence. But this clonic phase, is where they're having the muscular contractions, the muscle movement. And then the last phase, the fourth one, is the post-ictal phase. And post-ictal is when the seizure activity is done. Okay, the muscular contractions and all that stuff is done, and now your patient is quiet, basically. And the post-ictal phase is after that contraction, after the contractions end, all the way up to when your patient regains consciousness, full consciousness. Okay, during that post-ictal phase, you're probably going to have to do some kind of airway management. You may have to do head tilt chin lift just to open their airway, make sure that their tongue isn't blocking their airway. You may have to assist their ventilations if they're not breathing appropriately. But this last stage of the grand mal seizure is what we call the post-ictal phase. And that's when your patient has the return to his or her normal level of consciousness. Every patient is different. It may be quicker for some patients. It may be rather slow for others. And so during that post-ictal phase, you may have to suction. You may have to, do a lot of airway management. Okay. You may have some patients who have what's called an aura, A-U-R-A, aura. And that will be before they lose consciousness. So I don't want to add this in here as one of the stages because sometimes some people have it, some people don't. But basically, it's a warning sign that a seizure is coming, whether it's a visual disturbance or a smell. Sometimes you see people or you hear of people saying, they taste something, like there's a very distinctive bitter taste that they have, and they know that, oh, I'm about to have a seizure. Or someone says that they see something, they have some kind of visual disturbance, and that is the trigger for them that tells them this is coming. Not everybody has that though, so we don't want to add that as a stage. But it is possible for a patient to have an aura before their seizure happens. So the 4 phases of the grand mal seizure is loss of consciousness, tonic phase, clonic phase, and then post-ictal phase. And that post-ictal phase is really important because you're going to be doing a lot of stuff during that time. When they're contracting and they're having those rhythmic muscular contractions, you can't stop the seizure, right? You can't stop it. You can't hold them down. We don't put anything in their mouth or anything like that. Old wives' tale a long time ago was put something in their mouth so they don't swallow their tongue. Your patient's not going to swallow their tongue. But if you do put something in their mouth, then you just introduce something for them to choke on during the seizure. So we don't put anything in their mouth. We just stand by with our suction ready to maintain an airway after they're done. Okay. All you're really doing during the seizure is keeping track of the time, talking to the family if you can get any kind of information from the family, although most of the time they're pretty frantic and worried. And then you're making sure that the patient doesn't physically harm themselves during the seizure. So because they can't control their body and you won't be able to control their body either. So you want to make sure that they're not hitting their head on the floor or hitting their body against furniture or something like that. So if you need to move furniture or kind of protect them in that way, then you do. Okay. And when they stop seizing and that post-ictal phase starts, get your airway, get your suction and have your stuff ready, because as they're going from unconsciousness after they stop seizing and they start to improve all the way up to full normal level of consciousness, you may have to do some airway management. Which leads us into number 11, status epilepticus. So status epilepticus is a very distinct kind of seizure. Okay, and we worry about this because it is a life threat, and it's a life threat because of a couple of things. One, it could be a very long seizure, so something that is over 5 minutes without any kind of rest or anything. Or if your patient has, let's say your patient has no post-ictal phase. And remember, that post-ictal phase means they come all the way back to full normal consciousness. If you have a patient who has a seizure, they go through the rhythmic contractions, they do all that kind of stuff, they lose consciousness, they go rigid, then they contract, and then they stop. And then they're unconscious for a couple of minutes, and then they go and they have another one, That's status epilepticus because they didn't have their full postictal phase, right? They have to have a complete regain of their normal level of consciousness in order for them to have a full postictal phase. So if they have a really long seizure, one that lasts a long time, or multiple seizures back to back without that full regain of consciousness in that postictal phase, that's considered status epilepticus. And we worry about this because the patient is not, they're not ventilating correctly for those long periods of time, whether it's during the seizure itself or during that postictal phase when, when they can't really control their own airway. So you will have a lot of airway management to do. If it's lasting a long time, or again, if they go right back into another one, it may be time to call ALS. Because if you get those paramedics on your scene, then they can give the patient a medication to actually stop the seizure, or hopefully stop the seizure. So those are kind of things you need to think about. But make sure you know the difference between a regular seizure with those 4 stages we talked about and status epilepticus, because status epilepticus is definitely much more of a concern, okay, because of the length and the fact that they don't regain consciousness. All right. Number 12. I'm just going to be honest. I'm not going to go way into depth about number 12 because this is all about shock. And these are things that you guys should be good with from module 1. Okay. I will hit a couple or just do a brief review, but y'all should know about shock. Okay. Okay. So, remember, shock is one or more of 3 things that are wrong. You have inadequate heart function, inadequate blood volume, or inadequate blood vessel tone. One or more of those problems are going on, and it affects the stroke volume of your patient. So when the stroke volume goes down, your cardiac output also goes down, and so therefore you have hypoperfusion or shock, right? You have those 4 different categories. You have hypovolemic shock, that's a volume problem. You have distributive shock, which is a blood vessel problem where you have that systemic vasodilation. And remember, distributive shock is anaphylaxis, sepsis, and neurogenic. You have obstructive shock, which is, it falls under the heart function, the inadequate heart function. The heart, remember, the heart itself is not damaged in any way. It's just something is keeping the heart from doing its normal job. So it's compressed or something like that, like tension pneumothorax or the cardiac tamponade. And pulmonary embolism is also another cause of obstructive shock because it's obstructing the forward movement of blood through the pulmonary circulation and thereby keeping the stroke volume low. And then the last one that we talk about, remember, is your cardiogenic shock. That is inadequate heart function because the actual heart muscle is not working appropriately. The biggest one and the most common one is your acute myocardial infarction, which we'll talk about in just a moment. Okay, you can also have myocarditis. You can have a patient with congenital heart defect, but something to where the actual heart itself, the organ itself, there's something wrong with it. So please make sure you know your shock. And again, also remember the different phases of shock, because remember how important those vitals are. Your compensated shock, which is your early phase, is where you will have tachycardia and normal blood pressure. Your decompensated shock, which is your later phase, which shows that your shock has progressed, right, without being managed. You will have tachycardia, but now your blood pressure drops, so you'll have that hypotension, right? And then the very last phase, just for your awareness, is what we call irreversible shock, where you now have bradycardia, hypotension, and bradypnea. Everything's dropping, and you're just having complete failure in everything. But make sure you know compensated versus decompensated. Definitely, okay? All right. Moving on. CVA versus TIA. What's the difference between the two? So first off, know what they stand for, right? CVA is your cerebrovascular accident. TIA is a transient ischemic attack. Okay, so if you remember that and you know what those words mean, then that'll really help you, kind of know the differences between the two. CVA, which is your stroke, this is the inadequate cerebral perfusion, right? And we know what perfusion is. So if I have inadequate cerebral perfusion, that means that the blood isn't perfusing to my brain appropriately, okay? You can have two different kinds of strokes. You can have an ischemic stroke where there's a clot that is, inhibiting the blood circulation, or you can have a hemorrhagic stroke where there's a bleed inside the brain, okay? And if there's a bleed inside the brain, then again, the blood isn't getting to all the places it needs to get to. And unfortunately, when blood actually comes into contact with brain cells, those brain cells die immediately and we cannot get them back. Okay, so hemorrhagic strokes have a much more high mortality rate than ischemic strokes. Hemorrhagic strokes have a tendency to have a faster onset than an ischemic stroke, because an ischemic stroke is that clot is kind of building and building and building over time. But definitely know CVA is your stroke. It's inadequate perfusion of the cerebral tissue or the brain tissue. Your TIA is a temporary, and remember the T stands for transient, okay? So that'll help with temporary. This is a temporary blockage in the brain of the cerebral vasculature that produces symptoms of a stroke. However, those symptoms usually self-resolve within 24 hours. And when I say self-resolve, that means without intervention. We haven't done anything for them. We haven't, given them we haven't taken them to the stroke center where they got thrombolytics or anything like that. They just go away. Those symptoms just go away. Okay. A TIA, unfortunately, is kind of an indicator that your patient at some point will have an actual CVA. Okay, so if they have multiple TIAs, then it's an indicator that they're eventually going to have a stroke. Okay. Let's see. I can't remember if we go over this anymore. We don't. So I want to make sure I go. So a couple of things about that TIA. You don't know if your patient is having one, okay? Because remember, it's going to self-resolve within 24 hours. You don't have that patient for all 24 hours. It's very possible you only have them for 45 minutes of your patient interaction is only 45 minutes. And if they don't have, if they continue to have those symptoms throughout your time with them, then you don't know that it's a TIA. A lot of times what we end up doing is we take a patient later in the day to that hospital, and we kind of find out about that previous patient that we had. Oh, they didn't have a stroke. That's great. They only had a TIA. That's excellent. Okay. But because they both present the same way, they both have stroke-like symptoms, then I don't know at that moment if they're having a stroke or if they're having a TIA. And so I have to err on the side of caution, assume the worst, and assume that this patient is having a big stroke, because I've got to take them. I have to be, this is a time-sensitive kind of problem, so I need to quickly load and go, right? Quickly get them to the hospital and get them to the appropriate facility, that stroke facility that's going to be able to take care of my patient. If it turns out that this is a TIA, then that's fantastic. But I don't know that, right? I just don't know. So I basically treat it like a stroke because I don't know. I want you to think about your exams, right? How do we find those stroke-like symptoms? One of the easiest exams that we use is called the FAST exam, F-A-S-T. And I'm looking for facial droop, arm drift, and slurred speech. And the T stands for time. We'll talk about that in just a moment. The facial droop, you want to have them smile. Give me a big smile. Let me see those pearly whites. I want to see the smile. You want to see symmetrical movement, facial movement, where both sides are equal. If you have drooping on one side or the other, then that right there is a positive sign of a stroke. And it doesn't matter if they don't have arm drift or if their speech isn't, it doesn't matter. If the facial droop is there, That's a, positive sign. Load and go, stroke facility, let's go. All right. Arm drift, I'm looking for arm weakness. I'm looking for, weakness on one side. So what you want to do is, you want to have your patient close their eyes, and you want them to, excuse me. So close their eyes, put your arms out in front of you like you're walking like a zombie. But you want them to keep their eyes closed and hold your arms out in front of you. If one of the arms drops, or kind of drifts off or something, like they can't hold it up, then that's their weakness. That's the side that is affected, right? If you also wanted to do a grip strength test, sometimes I'll, maybe if my patient's really weak, or if I just want to feel for myself, then sometimes I'll have them do the arm thing I just talked about. And then other times I may follow it up with, I'll hold both their hands and I'll say, squeeze my hands as hard as you can, like you don't like me. Give me big, big squeeze, because then I can feel if there's weakness on one side or the other. Okay. So if the arm drift isn't like definitive, you're not quite sure, then do a grip strength. Okay. And then S stands for slurred speech. You want your patients to be talking appropriately. If they're just having trouble forming words, then that's a problem, right? If they're saying inappropriate words to the questions that you're asking, if they're not using the proper words to answer, then that's a problem. Okay. That's called expressive dysphagia, and that's a stroke. Okay. Because remember, a stroke is, you can kind of think of it as like a heart attack in the brain. Okay. You can kind of think of it like a brain attack. Okay. And we'll talk a little, I know we haven't talked about heart attacks yet. That's literally coming up next. That's on number 15. But you have, let's pull this up here. So you have go away. Cerebral perfusion blood vessels. Let's just look at that. Okay. I'm just trying to show you some images here. No, let me see like a CT. CT of cerebral vessels. There we go. Okay. So all these blood vessels, I guess this one's pretty good. Remember, your carotid arteries go up the sides of your neck, either side, right? Or both sides. And then they start breaking down. You don't need to know all of these anterior, middle, posterior. You don't have to know all that stuff. But I just want you to look at this and see how it breaks down, and it becomes all these little squirrely guys, right? Because all of these guys are perfusing the brain tissue. Okay. Now, granted, this is, the brain is circular. And so this is kind of broken into a plane that you can see, but it's super important that you know that, because if you have a clot right here, then guess what is not being perfused? All of this, right? So if there's a clot right here, none of this is being perfused. And this part of the brain, whatever this part of the brain affects, is going to be affected, right? So if your speech center is over here, then your speech is going to be off, right? If, part of your, you just kind of have to think of it that way, right? If the clot is right here, kind of further down, then it's only going to be affecting this amount of tissue, which is still a stroke, but the severity of the symptoms may not be as much as if the clot was here. Okay, so those are things you have to kind of think about, and the heart works the same way. We'll talk about that in a moment. Okay, so let's just show you. Let's see, cerebral blood vessels and ischemic clot. Nope, that spelled that wrong. Let's see if this shows me anything. Nope. I just looked at this the other day. What did I pull up? What did I pull up? Oh, ischemic clot in, well, let's see what that does. I want an actual, no, those are all like tumors and things like that. I want, here we go. This is not exactly, but there's that cerebral vessel, okay? There's a clot right here. And so this part of the brain is just white. There is no little worms, okay? Think of the little worms. Those are all little break-offs of all your blood vessels. There's nothing there. It is completely white. That's your ischemic clot. This is what it looks like when it's reperfused. When they remove that when they remove that clot, that's what it looks like, okay? It's blocked off right here. They remove that clot, and look at all of that blood vessels, all of those blood vessels that are now reperfused. And that means that this brain tissue is now reperfused, right? That's an ischemic stroke or a clot. A hemorrhagic stroke would be if this blood vessel was broken and the blood is escaping into the brain tissue. Okay, that takes a completely different kind of treatment and management. That's surgery and all that kind of stuff. But remember, where that blood actually, whatever brain cells that blood actually touches, unfortunately, those brain cells are done. And once they're done, they're done. Okay, so that's why we say the mortality rate of a hemorrhagic stroke is that much higher. But here's my thing about CVAs versus TIAs, okay? I don't know if they're having a CVA or a TIA, because at the moment, there's something temporarily blocking this. It could be a spasm, right? It could be like a vasoconstriction here at the moment, and it's vasoconstricting, and so there's not very much blood flow here. It could be some kind of tiny little floating embolus that maybe temporarily lodged itself there, or just was positional or something like that, right? But something has temporarily blocked this, and so therefore I don't have the perfusion to this area of my brain. So it still acts like a stroke, right? That FAST exam, I'll be positive on that FAST exam, positive for stroke-like symptoms. Okay, so I hope that makes sense. And we'll pull up some more in just a minute. So CVA versus TIA, and the FAST exam is the easiest, fastest, hence the name FAST. Facial droop, arm drift, slurred speech. The T is incredibly important because the T is the time, okay? And when we go by the time, I don't go by when these symptoms appeared. I go by when this patient was last seen normal. That's what we go by, okay? Because it's very possible. Let's say, for example, like right now it's 11:50 p.m. It's almost midnight, okay? Normally we would be sleeping right now, all right? But let's say that we wake up in the morning and it's 6 o'clock in the morning, and we wake up and we have slurred speech. First thing in the morning, wake up with slurred speech. Well, that means that the last time that means that it happened anytime overnight. That's why we can't go by when the symptoms appeared. We have to go by when the patient was last seen normal. And if the patient went to bed at midnight, then midnight is the time that we go by, because that's when the patient was last seen as normal without symptoms. And so when you're talking about time windows, time is extremely important in your stroke patients, okay? Because unfortunately, once you're outside of a certain window, and for most strokes at this time, it's about 4 or 5 hours. Once you're outside of that, the patient's treatment options change, and they're not as many, right? So that's why we talk about how important and how time sensitive a stroke patient is. Okay, if you get on scene and they're slurring their speech, that's the first thing you notice, right? Manage those ABCs, get them over to the cot, get them in the back, and go. You don't have to. I mean, you're going to assess them en route, but you don't have to assess them on the scene. You know what's going on, so get them to the hospital, right? Okay. CHF, congestive heart failure. So congestive heart failure is where the heart is not pumping appropriately, all right? You can have left-sided CHF, you can have right-sided CHF. Normally, when we think about CHF, we think about left-sided, because remember that left ventricle of the heart, that's what we call the powerhouse, or the powerhouse of the heart, because that left ventricle is what pumps to our body, right? So congestive heart failure is a disorder in which the heart loses part of its ability to effectively pump blood, usually as a result of damage to the heart muscle. And this results in the backup of fluid. Okay, now, super important, left-sided versus right-sided. I want you to think about that drop of blood and how it circulates, right? Because if this is right-sided failure only, then that means that it's going to back up, the fluid is going to back up into the body, right? Because the right side receives blood from the body and pumps to the pulmonary circulation. So if the right ventricle isn't pumping appropriately, then it's going to back up into the body, and I'm going to have what's called peripheral edema. And when I mean peripheral edema, that means swelling in like your lower extremities. Okay. If you have left-sided failure, and that left ventricle isn't pumping to the body, and remember, the left side of the heart receives blood from the pulmonary circulation, receives that oxygenated blood from the pulmonary circulation, and then the left ventricle pumps it to the body. If the left ventricle isn't pumping appropriately, then it backs up into the lungs. So you have to think about where it backs up into. And if I have fluid in the lungs, I have pulmonary edema. And if you hear crackles and rails, patients short of breath with crackles and rails, that's pulmonary edema, that's left-sided heart failure, congestive heart failure, okay? Congestive heart failure, your patient's main or chief complaint is not going to be chest pain. A lot of people, for some reason, they think because it's heart that your patient's going to be experiencing chest pain. But most of the time, it's actually shortness of breath, because the heart isn't hurting, okay? The heart is just not pumping like it should, and so the fluid is backing up into the lungs, and now they can't breathe. Okay, so CHF is a disorder in which the heart loses part of its ability to effectively pump blood because the heart is damaged. Most likely the heart muscle is damaged, and there's a backup of fluid. If it's left-sided, then the fluid backs up into the lungs, causes pulmonary edema, shortness of breath, and decreased cardiac output. If it's right-sided, then the fluid backs into the body and causes peripheral edema. Okay? Left-sided heart failure will eventually cause right-sided heart failure. That's why normally when we say CHF, we just kind of think it's left. The treatment for CHF is ABCs, airway breathing, circulation. I'm going to give them oxygen, put them on CPAP. Put them on CPAP. If they're not breathing adequately, though, I can't use CPAP and I have to bag them, right? Sit the patient upright, make sure that they are sitting as upright as possible so they can have the best gas exchange with their alveoli, and put them on CPAP. Bag them if you need to. Okay. If you look at, remember I said we were going to look at that lookalikes PDF. If you go to your schedule here, here's that lookalikes PDF. So if we pull this up and we take a look at this, you've got CHF versus pneumonia. Okay. Here's pneumonia. We've got crackles. That's spelled wrong. Bronchi, rails, green sputum, fever, right? Shortness of breath. Congestive heart failure, shortness of breath. Wet lung sounds with pulmonary edema. But we've got pink frothy sputum coming up, or edema in the extremities. So the color difference is big. Okay. This pink frothy sputum is because your patient, when they have so much pulmonary edema in their lungs, it's going to be blood tinged. So that's where the pink comes from. And if their lungs are completely full of fluid, where does it go? It goes up and out the trachea, out the mouth. Okay. Think about filling up a water bottle. Okay. When it's totally full, it just pours out the top. And that's literally what's happening with this patient. If their lungs are completely full of fluid, then that fluid has to have some place to go, and it comes up and out their trachea, out their mouth. And you're going to see pink, frothy sputum. The frothiness is because it's oxygenated, right? There's like bubbles. So make sure you know the difference between the two. Those colors really kind of help you with that. If you look at this, the treatment, a lot of similarities, right? CPAP if you absolutely need to, but sit them upright, give them oxygen, and get them to the hospital. Okay, CPAP definitely for your CHF. If we look at your right-sided versus your left-sided, your right-sided, because it's the right ventricle that's affected, you're going to have swelling or edema in your body with that peripheral edema, with the lower extremities. If it's left-sided, then shortness of breath with pulmonary edema. Okay. So again, looking at this lookalikes thing is extremely helpful. And I think we get into CHF more a little bit later, don't we? Maybe we don't. All right. Well, anyway. So CHF, pulmonary edema, pink frothy sputum, put them on CPAP. They need it. Okay. If you want to look at your book, table 16-4, 16 is your respiratory emergencies, is a very good comparison of CHF and COPD. So they kind of put those next to one another, kind of like that lookalikes, but they go really in depth. So that's a great table to look at, table 16-4, to kind of compare the two. All right, number 15, signs and symptoms, differences of signs and symptoms between angina versus your acute myocardial infarction. So now we're going into our cardiovascular emergencies, okay? So angina and your acute MI are both going to present with chest pain, okay? So the main symptom is, if you want to think about, we talked about COPD earlier and how you have two things underneath it. You have emphysema and chronic bronchitis. Think of these guys as being underneath what's called acute coronary syndrome, or ACS. So acute coronary syndrome, the main symptom is chest pain, and you can have angina or your acute MI, okay? So the differences between the two, and you can find this on your lookalikes tab. There it is, acute coronary syndrome, the MI versus angina, myocardial infarction versus angina, okay? So make sure you take a look at this. We're going to review it, but make sure you take a look at this. So for angina, this is chest pain that occurs when a portion of the heart needs more blood than what the coronary arteries can provide at that time. Okay, so we talked about the brain. It's the carotid arteries that supply blood to the brain, but the coronary arteries supply blood to the heart muscle. Okay, so this is a problem with the coronary arteries. So angina is when the heart needs more blood than the coronary arteries can provide at that time. It's usually during exertion. Okay, some kind of physical exertion or something like that. The pain of angina is temporary, usually subsiding when that physical exertion stops, okay? The key point of this is the cardiac cells, although they're not getting as much blood as they need, those cardiac cells are not dying. They're getting enough blood to function, but they're not dying, okay? The pain from angina usually will resolve within 10 to 15 minutes. Most of the time, when the person stops doing whatever it is that is causing the pain, that physical exertion, and if they have a history and they have nitro at the home, most of the time it'll go away with nitro. Okay. So think about that person who is mowing the lawn or is working out for the first time in a long time, or doing something physical and they start having chest pain. Okay, pain is your indicator that something is wrong. So they're going to stop, right? They're going to stop and rest. And after like 10 to 15 minutes, that pain goes away because they're no longer doing that physical exertion. Okay. because the pain is temporary, and it will usually subsides when that exertion stops. Those cardiac cells are not dying. That's the key point. They're not dying, okay? The cardiac cells. However, your acute myocardial infarction, on the other hand, this is different because this is an occlusion, partial or complete, but it's a partial or complete occlusion of that coronary artery. It could be more than one coronary artery, but it's an occlusion that's preventing blood flow or blood supply from reaching part of the heart. The cells are absolutely not getting enough blood, and so the cardiac cells will start to die in an acute MI, okay? The acute MI can quickly progress to cardiac arrest if it's not fixed. So this is another very time-sensitive kind of thing, okay? Very time-sensitive. Most of the time, your acute MI, because it's an occlusion and the pain doesn't go away with rest, this is, pain that's been going on for at least an hour or more. So it's just kind of a general rule of thumb. You can kind of think of it that way. Angina will go away with rest, approximately 10 to 15 minutes. Acute MI is going to continue for a long time because it's an occlusion, and that pain will continue until that occlusion gets removed. And that can only happen at the hospital, right? Okay. You can give your aspirin and your nitro, but it will only temporarily manage what's going on. That patient needs to get to the hospital. So looking at this lookalikes thing, then the MI is a blockage of the coronary artery, most of the time complete. We've got that chest pain. Pain can radiate to the neck, jaw, left arm, or back. There's supposed to be a comma in there. Over 10 minutes, over 15 minutes, up to an hour or more. Nausea, diaphoresis, that kind of thing. Okay. Angina is the partial blockage. It normally will subside in less than 10 to 15 minutes because the pain is temporary. If you look at the treatment of it, the treatment is the same. I'm going to treat it the same because they're both chest pain and I don't know what's going on. So I treat it the same. Oxygen, if their pulse ox is less than 94%, aspirin and nitro. If they're, if there's no contraindications, okay? So make sure you know the difference between your acute MI and your angina. Okay? And if you want to think about, let's see here. I want to look at a cardiac cath picture. That'll work. Okay, here we go. So we saw pictures of the brain, and then I want you to see. Oh, hang on. I want to see before and after. There we go. So we saw pictures of the brain and kind of how this works, right? Because you can think of the ischemic or the clot in the brain. It's the same thing in the heart. Okay, so here's your coronary artery, but there's a blockage. There's a big old blockage somewhere, okay, because I don't see a lot of that vasculature like I should. So they go in, they take their little wire, they go in, they do what they got to do, they pull out that clot or they break it up, and now look at all that perfusion, okay, that's now occurring. So they have now reperfused the heart tissue. When you give aspirin and nitro, that's the beginning of the reperfusion, remember, because nitro causes vasodilation, and so it increases the blood flow to that tissue. But the definitive treatment is to get your patient to a hospital that has an acting cath lab, right? So it has to be a cardiac accredited hospital. That's one picture. Let's look at another one. This is an awesome picture right here. Let me see. Here we go. Okay, do you kind of see that looks like it just looks like there's a break in it. Okay, so it's not flowing all the way through. Well, they just reestablish blood flow. Okay. So that's what happens in the heart. And you can look at all these. This is a really great one. This is a complete block right there. It is just it just stops, and there's nothing over here. They reperfused. They went in. They put in a stent. They open it back up. They suck that clot out, and look at now how beautifully reperfused this is. Okay, so that's what's going on when you have an acute MI. Okay, there's a partial or complete blockage, and it is all those cells that are distal to that where that blockage is